Uh, if we have to perform an hemodynamic study by catheterization, we do simultaneous the left head and right head catheterizations, and we assess the pulmonary capillary wedge pressures and LVEDP. Both in raised and in indeterminate cases, we have to advise certain supine exercise that can further will delineate the LVEDP and pulmonary capillary wedge pressures. The treatment approach is, management approach is multi-pronged, starting from the non-pharmacological measures like obesity reductions, cessation from smoking, etc. Treating the comorbid condition is of paramount importance. You need to treat your hypertension, diabetes, CKD, sleep apnea, and there are very limited scope for pharmacological and certain device-based program is there. So until very recently, diuretics is the only drug which were recommended, incorporated in the guidelines. It is only used to relieve the congestive symptoms and use the lowest possible dose and stop once euvolemia achieved to avoid diuretic-related complications. Then come the RAS inhibitors, the CHARM trials, Preserved trials and all. They didn't show any remarkable changes with ARBs. Only in CHARM trial there is modest reduction of heart failure hospitalizations. It's still used only to treat the coexisting conditions such as heart failure. ARNI, which has been considered is a magic drug while treating the heart failure in reduced ejection fractions, whereas in the heart failure preserved ejection fractions, the data are not so promising. In Paragon heart failure trial, they show there is no reduction in the incidence of the primary outcome of severe death and heart failure hospitalizations. But if we look into the data more carefully, the subtype analysis, there are certain benefits found in the women and in patients who are LV functions is in the bit lower side, where the LV function is less than 57%. And the Paraglide heart failure trial, there were a reduction of NT-proBNP from the baseline after in 8 weeks, but there was no improvement of the quality of life. So regarding these findings, the US FDA recently approved ARNI in selected cases of heart failure preserved ejection fraction, where specifically when the LV function is in less than 60%. Once again, beta blocker, the trial is not encouraged. It's just used for the coexisting conditions like atrial fibrillations, post-MI and angina. And MRAs like spironolactone, who have shown to have potential benefits in reduced ejection fractions, but the MRA trial, the TOPAC trial, conducted in HFpEF with spironolactone, there was not a significant benefit in the primary outcomes, but in very subtype analysis, they found that there was reduction in individual component of heart failure hospitalizations, particularly when the LV function was in the less, and there were huge regional variation of the TOPAC trial. People in Northern America, they responded well with spironolactone, whereas people in Russia and Georgia, they didn't fare well in this trial. In the recent concluded trial of Finarest HF trial, it's done with finrenone, it's a new generation's MRA. They found some encouraging result, but more and more trial needed with the molecule of finarene. So that's why finrenone is not incorporated if any of the guidelines yet. Then come the SGLT2 inhibitors. It is traditionally, we know that it is an anti-diabetic medications, but they have potential cardiovascular benefits, as it demonstrated that effects in the heart failure in reduced ejection fractions by the earlier trials. So that has encouraged to study empagliflozin and dapagliflozin in HFpEF also. The Emperor Preserved and Delivered trial that shown that there is a reduction in the primary outcome, the severe death and heart failure hospitalization. But if we go through the trial more carefully, these outcomes were mostly driven by the reduced heart failure hospitalizations part. There was no statistically significant outcome in diminishing the cardiovascular mortality. Another thing we found with particularly the empagliflozin, there was more improvement of the health status and more additive benefits of the MRA, particularly patients with who are receiving MRA spironolactone. The commonest cause of discontinuation of MRA is hyperkalemia, but if we concomitantly used with empagliflozin, so there are lesser incidences of discontinuation of MRA because it causes lesser chances of hyperkalemia. So depending on those trials, European Society Cardiology has given a class 1 indication in of SGLT2 inhibitor in the management of HFpEF, where the ACC, they're giving a class 2 indication of SGLT2 inhibitor in the HFpEF. Vericiguat, which is a soluble guanyl cyclase inhibitor, it has shown excellent result in heart failure reduced ejection fraction as shown by the Victoria trial, whereas the in HFpEF, this is a trial called Socrates Preserved trial. The trial didn't show any benefit in the management of HFpEF. We know that HFpEF is associated with a lot of metabological derangement, obesity. So semaglutide, which is still an endocrinologist domain, so the trial showed some improvement of quality of life and improvement of exercise tolerance, though it's not been incorporated in the guidelines because more studies are needed. So I'm going to talk about the device, which is in HFpEF, one of the commonest problems we encounter is the fluid liability state. Sometimes patients become bloated, sometimes very dry. So this is a CardioMEMS is a device which is a small, tiny, invasive device implanted by transcatheter in the pulmonary artery, which will measure the pulmonary artery and which will transmit the data to the treating cardiologist. So this transmitted pulmonary artery pressure will exactly tell us about the fluid status of the body. If in the impending heart failure cases, there will be elevation of pulmonary artery pressures, and depending on that, we can do titrative fluid balance, and as well as we can augment the diuretic doses. So Champion trial was conducted with this device, and which shown a remarkable result with significant reduction of the heart failure hospitalization. So ACC has recommended 2 minutes please. Class 2B indications, particularly is indicated when there is recurrent hospitalizations despite GDMT and who have a cardiorenal syndrome. So this is a pictorial demonstration with a radiological picture of this device. So in a nutshell, this is summarize the guideline recommendations when the diuretics has been given class 1 recommendation, but it's only to relieve the congestive symptoms, where the ARBs and the MRA has given class 2B recommendations by the ACC, but the ESC didn't give any recommendation, just been asked to treat the coexisting conditions. Rest of the drugs still not been incorporated by any accredited guidelines, and the CardioMEMS device has been given class 2B recommendations. This algorithm, this chart, which must understand for the treatment of HFpEF. Once we have established the diagnosis of HFpEF, if there is no other contraindication, you begin SGLT2 inhibitor as soon as possible. And if the patient is fluid overloaded, you give and titrate the diuretics. And despite diuretics and SGLT2 inhibitor, if the patient's having still congestive symptoms and frequent hospitalization, you start MRA. And for MRA, you have there is a gender specific guideline difference. For women, we have to use in all kind of EFs, whereas the male we have to use where the LV function is less than 55%. And if the patient is still having recurrent hospitalization, we can use ARNI for women all spectrum, and for men where the LV function is less than 55, and in ARNI eligible cases we can use ARB. So why there is the gender specific protocol difference? So there's a hypothesis is that the both ARNI and MRA, they act better when there is low LV function. And for women, the remodeling is more concentric, where men remodeling is more eccentric. So when we have a concentric remodeling, there is a small LV volume, and when we estimate LV function by echo, it's end diastolic volume by end systolic volume by end diastolic volume. So naturally we underestimate LV function when a concentric remodeling. So women of LV function 70% in a heart failure preserved ejection fraction can have an actual LV function of LV function less than 50. That's why women across the EF, the ARNI and MRA recommended, but for male, when their LV function is less than 55%, then only it's recommended. These are starting and target dose we must have. Now I will be just briefly talk about a case scenario as interesting case. A 57-year-old lady without known hypertension and diabetes presented with NIOHF 3-4 dyspnea, palpitation, and anosarca. She was hypotensive with irregular pulse, atrial fibrillation with low ventricular rate, normal KFT, slightly low hemoglobin. So when we did an echo, we found there is an concentric LVH. This is the LV septum posterior wall. This is concentric, and we measured the LA. Left atrium was enlarged, is 46.5, and the if we function assess the LV function by TCOS, this is LV function was 62%, and that both the septum and posterior wall was quite thick, 16 and 19 respectively. And this is a four chamber view. We can see the right atrium is also dilated, and mild pericardial effusion we can see. And this is IVC, so classical heart failure scenario, dilated IVC, and this is pleural effusion, this is collapsed lung. So patients having normal LV function, dilated LA, concentric LVH, biatrial enlargement with heart failure scenario. And this is a Doppler tracing. We can see the E by E A ratio is 4.47, and the measured the E prime, so E by E prime was around 16-17. So patient having concentric LVH, without hypertension, without aortic stenosis. So we needed the further investigation. As was mentioned, in some of the cases we need to reinvestigate. So I sent the patient for cardiac MRI. This is a cardiac MRI showed patients having a cardiac amyloidosis. And for the hematological investigations, I sent the patient to the hematologist. They found the patient suffering from multiple myeloma. So that's how we can reach at a diagnosis. So it's a very complex situation. So my take-home message that it's a very complex heterogeneous disease. The concepts are evolving. Only therapeutic options being the diuretics, SGLT2 inhibitors, certain cases ARNI and MRA, and management of comorbidities. Ruling out mimics are extremely important, and most importantly, it's not only the domain of the cardiologist, it's a multidisciplinary approach needed comprising of endocrinologist, nephrologist, and the pulmonologist. Thank you for patience hearing.